Hi, everyone, and welcome to the ARBEST monthly webinar series. Today's topic is Early Adversity in the Developing Brain, Translating Neuroscience into Tailored Clinical Intervention. My name is Laura Landers, and I'll be your webinar moderator for today. So before we get started, I just want to let you know a little bit about the ARBEST program and introduce our speaker. The Arkansas Building Effective Services for Trauma, or ARBEST, is a state-funded program at the UAMS Psychiatric Research Institute. And our aim is to improve mental health services for children and families who've experienced trauma. We work closely with multiple partners to build a more trauma-informed state, and we're probably best known for providing training to mental health professionals on treatments that are effective with helping children and families recover from trauma. Just a few housekeeping announcements before we get started. We encourage you to use the chat feature for any questions or comments that you might have throughout the webinar. We'll be monitoring the chat throughout the presentation. And if you're interested in receiving CEU credits for this webinar, stick around to the very end and I'll give you more information on how to obtain those. We will be recording this webinar and uploading it to our ARBEST YouTube channel. We have other previously recorded webinars there, so you can check those out. And be sure to like us on Facebook, where we post upcoming monthly webinars, training opportunities, and other resources. I'm very excited to introduce today's presenter, Dr. Megan Calvert. Dr. Calvert, would you like to tell us a little bit about yourself?
Yes, I am a clinical psychologist. I graduated from the University of Arkansas in Fayetteville with my PhD in 2019. I then did a clinical postdoctoral fellowship specializing in the treatment of children in foster care, both assessment and intervention strategies best for those children. And then I took on a second postdoc training position in computational neuroscience to learn about the ways in which the brain develops, and we can use modeling to sort of predict how the brain is functioning and how we can increase the effectiveness of treatments for children over time. And so currently I'm an assistant professor at UAMS in the Brain Imaging Research Center, and I provide evidence-based treatments to children who have experienced adversity at the Child Study Center.
Excellent. Thank you so much. Whenever you're ready, please just take it away.
Okay. So today I'm going to talk about early adversity and the developing brain, with a focus on translating neuroscience into tailored clinical intervention. So to talk about neuroscience, we'll do a brief neuroimaging primer, and then we'll talk about neurobiological systems that are affected by adversity. We'll talk about the brain changes contributing to emotional and behavioral functioning, and we'll apply these developmental neuroscience principles to think about how we might tailor our interventions to treat children most effectively. So our brief neuroimaging primer. Yes, the handouts will be available after the slideshow. So the brain is made up of gray matter and white matter. Gray matter is the neuron cell bodies, glial cells, and dendrites, while white matter is the axons of those neurons. And the white matter connects all of the neurons to communicate. There are different modalities for neuroimaging. Today, I'm going to focus on MRI, magnetic resonance imaging, and also functional near-infrared spectroscopy. With magnetic resonance imaging, you can get structural pictures of the brain, and you can also get functional pictures of the brain. Functional pictures sort of let us know, that data lets us know how the brain is the activity in the brain when somebody is either at rest, and that's called resting state functional connectivity, or activation, task activation, which is we're going to ask somebody to do something and we're going to see the brain's response to that particular task when they complete the task. The other modality that we'll talk about today is functional near-infrared spectroscopy. This modality uses an array of sensors and detectors to pass near-infrared light through the skull and to the cortex, and then that light is then refracted back up, and the amount of blood in the area is what we're looking to detect. And on our slides here, you can see what the functional near-infrared spectroscopy sort of output looks like. It looks a lot like functional magnetic resonance imaging, although it does not have the subcortical structures. Functional near-infrared spectroscopy can only measure cortical activity. But the really interesting thing about functional near-infrared spectroscopy is that you can use this technology in everyday settings. So whereas in the MRI, children are constrained, it's hard to get really good data because the children need to lay very still. Functional near-infrared spectroscopy can allow the child to move around, interact with their caregiver, as you see in this picture here, and it can measure brain activity in both participants at the same time. Okay, so we'll keep those two technologies in mind as we move forward. I'm only I'm going to talk mostly about functional networks today. And so I'm only going to briefly review structural development, and we'll spend most of the time in the primer reviewing functional development. So most neurons are produced prenatally. There are a limited number of neurons that are created after birth, and they tend to migrate to the hippocampus, the ventromedial prefrontal cortex, the cingulate cortex, and the superior frontal gyrus. Production of glial cells, which, if you remember, go into the gray matter. Those are produced throughout childhood and adulthood, and glial cells help to organize neural circuits. In infants, by about 2 to 3 weeks after birth, the brain volume of an infant is about 35% of that of an adult. And then by 2 years of age, the brain volume is about 80% of an adult's brain volume. Throughout development, we see an overall reduction in gray matter and an increase volume of white matter over time. The white matter development is linear, so we see a gradual increase over time, and the rate of that change tends to be stable, except where axon growth is fastest in the first 5 months of life, postnatally, and then myelin, so the fatty substance that that coats the axons to make sure information is moving quickly in the brain. Um, the myelination develops through infancy and through adults. By about 2 years old, the hippocampus, so the sort of what's responsible for memory, has levels of myelination that are consistent with adults. Um, and some areas of the hippocampus continue to develop. This is really important to think about. So as I start talking about age groups and the functional changes we're seeing, it's important to keep in mind that by age 2, the child's brain, the size and the number of neurons are going to be about the same. Um, so with gray matter, the gray matter density, so the amount of cell bodies that we have, is a curvilinear relationship. And that means that the rate of change over time changes, it's not stable. What we see is that gray matter peaks actually during childhood and then decreases um, throughout adolescence and uh, sometimes increases a little bit more in adulthood or sort of stays flat. The pink brain over here to the right, we have a gray matter density map. On the y-axis is the density of gray matter in specific areas, and then on the x-axis is age. So as we can see here, in your prefrontal cortex, sort of we have a high density, um, less than 10 years old, and then we start to decline over time. Um, okay, so now we'll move on to functional development. Functional development throughout childhood is complex and it's variable, and it's dependent upon genetics, age, so you'll see different um, functional associations at different times in the lifespan. And this can also be altered by environmental influences. What we know is that connectivity increases in all regions in the first area of life, but that connectivity increases most quickly in primary areas where, you know, infants need to be able to grasp, they need to be able to see, they need to be able to hear. So all of those primary senses are our primary kind of areas, and they develop most quickly in the first year of life. And then the rest of the brain, the association areas like the prefrontal cortex, um, the executive control network, all of the networks and circuits we'll talk about later, those tend to be slower and they develop throughout childhood and adolescence. Regions that are connected structurally also tend to be related functionally, but that's not always the case. It's not a one-to-one mapping. And so we'll talk a little bit about networks because that's sort of where our focus will be. The by age 2, The default mode network, the dorsal attention network, and the salience network start to show that they are a network. They're activating at the same time um, by about 2 years of age. So just like we saw that by 2 years of age, we had 80% brain volume as an adult, we're seeing network properties by 2 years of age. And actually, the default mode network, which facilitates self-awareness, starts that network structure, which is functional. So we see activations in regions associated with the default mode network by 6 months of age. And it's the first network outside of our primary areas to develop. Really important is the connectivity between the thalamus and the cortex. The thalamus, if you remember, is the relay system of the brain, right? So all of the inputs that are coming in from the environment are filtered through the thalamus, and then those messages or signals from the thalamus go into the cortex. So the connections from the thalamus into the cortex are very important. And we see that those connections start to really take off between 1 and 2 years of age. And the salience network, which we will talk about in more detail later, connects with the thalamus and the salience network. That functional connectivity predicts cognitive ability, it predicts working memory, even at age 2 years old, at age 2. Let's see. So as we move past infancy into childhood, information is segregated at first, and then it starts to integrate over time. So these networks start talking to each other more and more over time. And interestingly, the functional associations, so two brain regions are active at the same time, that those functional networks, that functional connectivity actually develops before the structural covariation. So before an axon fully meets to the next region. So that's pretty interesting. And then we move into adolescence, and we start to see some decreases in network connectivity along with some increases. So if you remember, I said that different ages have different associations or connections at different times. And so here we can see that the connections are starting to change. There's a decrease in the short range connections, and then there's an increase in long range connections. So in this figure, connectivity increases with age. So we see in this, in A, we have the hippocampus and the amygdala are increasing their connectivity as as adolescents get older. So we go from age 10 to age 30, and we see an increase in that connectivity. But if we look down here, we see that there's a decrease in connectivity between the dorsal anterior cingulate cortex and the hippocampus, and a decrease in the connectivity between the frontal medial cortex and the putamen. Interestingly, most of these effects are for both male and female adolescents, but as we see here, the connectivity between the hippocampus and the amygdala, boys have more amygdala hippocampus connectivity throughout development, and girls have lower levels even as they're both increasing. Okay. So that's just a short primer on neuroimaging and neural development. Now we're going to talk about the neurobiological systems that are affected by adversity. And just as a reference, these are the networks that we'll be talking about. So I referenced the default mode network, and that is the first network outside of the uh, motor networks to develop. And we see here we have some frontal activity, the attention network that we'll talk about brings in the higher order cognitions like working memory, attention, obviously. And then we have the limbic network, and that is, we have our orbital frontal cortex and our amygdala, hippocampus in there. So this is just sort of a visual of what these different networks look like. And we're talking about functional networks. So these are regions of the brain that show activation together at the same time in a coordinated way. And first, we're going to talk about functional connectivity just as people are at rest and children are at rest. So typically in the first couple of years of life, that means they're sleeping because in an MRI, infants have a very hard time and children have a very hard time holding still. So typically they're sleeping, but this gives us a good estimate of their resting state network. And a little bit later, we'll talk about some task activation. So we'll start with the default mode network. That's the first network that develops. What we know is that income and maternal education are associated with network connectivity in both the sensory motor network and also the default mode network at 6 to 12 months of age. So already we know that lower income and lower maternal education is impacting the development of the default mode network. We also see that parental conflict is associated with increased connectivity between regions within the default mode network. So the posterior cingulate cortex has increased connectivity with the rostral anterior cingulate cortex. And the anterior medial prefrontal cortex and the anterior medial prefrontal cortex all have increased connectivity. We also see increased connectivity between these regions of the DMN and the amygdala in very young children when there's parental conflict. So when we, in the emotion regulation network or the limbic network, depending on which researchers are writing their reports, we see that maternal depression is associated with hyperconnectivity. So that means the amygdala and the medial prefrontal cortex are firing together more often than you would expect in a typically developing infant. And we see this at starting about 6 months of age. We also see that parental conflict, as I sort of alluded to, increases the connectivity between the posterior cingulate cortex and the amygdala. And we also see that prenatal drug exposure is associated with increased connectivity between the amygdala and the medial prefrontal cortex. And this finding is found in multiple types of substances. It's not specific to one particular substance. One more unique finding is that prenatal marijuana exposure is associated with striatal, so the striatum and the insula connectivity at 4 weeks post-gestation, so post-birth. I think guess I'm really trying to point out that we start seeing these functional differences already, even in infancy. And then these differences can continue if there's not a mediating or moderating factor. So when we look at adolescence, we see that poverty is associated with reduced connectivity in the central executive networks. So someone's ability to pay attention, their ability to make good decisions, all of that is sort of tasked or determined by the central executive network. And we see that when adolescents grow up in impoverished communities, they have reduced connectivity in that particular network. They also tend to have reduced connectivity in the emotion regulation network, so that limbic network that we talked about earlier. A network that wasn't previously shown is the reward network. And this it links the subcortical structures to the prefrontal cortex. And again, these are activations that are co-occurring at the same time. And what we see there is that income and neighborhood poverty is associated with the connectivity between the ventral striatum and the prefrontal cortex. We also see that maltreatment specifically is associated with decreased connectivity between the ventral tegmental area and the hippocampus. But children with maltreatment histories also have increased connectivity between the salience network and the hippocampus. So we'll talk a little bit more about what this means in a moment, or how we could expect to see behaviors and emotions be different based on the decreases in connectivity or the increases in connectivity. Okay. So I so in thinking about task activated or task activation, so the parts of the brain that become more active during certain tasks, we see that we have, and this is a pretty consistent finding in uh, most or all adversity studies. And so it doesn't actually matter which type of adversity, it's sort of a non-specific brain adaptation to adversity in general. So there's an increase amygdala activation in response to any type of emotion processing task or in response to even viewing emotion faces. So asking the child to just sit and watch the faces, we see amygdala activity more than peers who have not experienced adversity. We see reduced activity in the prefrontal and striatal regions in response to emotion processing and in response to happy faces. So, and this is among children who experience poverty. We see increased activation in the DLPFC during social rejection in children who experience maltreatment as compared to their non-maltreated counterparts. And we see increases in salience regions of the salience network during emotion processing tasks in children who experience maltreatment as compared to children who did not experience maltreatment. Okay, so I've talked a little bit about what the findings are in the literature, but really, what does all that mean to behavior, to child emotion, what we see every day in the clinic or when we're interacting with our own kids? What does all of that mean? So, increased connectivity in the default mode network may reflect rumination. And rumination, as you know, is often linked to depression and other mental health difficulties. So if we have strong DMN activity, um, this increased connectivity can suggest that maybe this child or this person has increased likelihood to ruminate and think about themselves and the world just a little bit more. Uh, Hyperconnections between the amygdala and the medial prefrontal cortex may reflect inefficient emotion regulation and reduced network flexibility. So instead of the brain being able to switch tasks or be able to uh, move to a different pathway, it's inflexible. The brain is going to respond in the same way each time. And whether it's inefficient emotion regulation or it's reduced flexibility, um, it really increases the likelihood of dysregulation, both emotionally and behaviorally. When there's strong connectivity between the amygdala and uh, the posterior cingulate cortex, we see that. Um, so, if you remember, the PCC is part of the default mode network. So, we see an increase in self referential thoughts, but because of that increased connectivity with the amygdala, that increased self-thinking is more likely to be negative, or reflect some kind of um, threat processing, and it's likely to reflect some kind of rumination. And then when we see reduced connectivity in the executive network, we're likely going to see impulsive behaviors, difficulties with poor decision making, and difficulties with emotion regulation. When we see increased connectivity between the ventral striatum and the prefrontal cortex, we're likely going to see a bias in a child's behavior towards reward seeking or compulsive behaviors. Um, and then when there's a decrease in connectivity between the ventral tegmental area and the hippocampus, we can see a reduction in the child wanting to try new things. They may also experience reductions in satisfaction. Um, and then when we have an increase in connectivity in the salience network and the hippocampus, we're going to see a bias towards searching for threat, and experiencing um, the environment as threatening, or at least could be threatening. So when we think about the development of the brain, and then the brain and behavior adaptations that are associated with adversity, um, how do we use this information to think about how we treat our patients, or at least how we think about what might be going on for them? So, sort of as we think about treatment, right, we have to start at assessment. And we really want to assess all forms of adversity during intake and throughout our work, because we know that environments change, family circumstances change. And if a parent loses their job, well, maybe that puts the family in poverty, or it puts them in a really difficult financial situation. Um, and then if that's happening, right, then we can start to see some brain behavior effects of that. So we always want to make sure that we are assessing continuously for these different adversities that might occur. It also really suggests that we need to assess the way the parents um, grew up. What kind of environment did they develop in? Because these brain behavior associations tend to be longer term adaptations. So it's the adversity, the experience of adversity sort of gets baked into the brain's development. And so, if the parent has experienced some of these things, um, and there hasn't been any intervening variables to sort of put the brain on a different track, um, we should consider that as part of our intervention. Is this parent going to be able to do this thing consistently if they experienced poverty growing up and their central executive network isn't well developed, right? Um, and so we need to think about the way the parents, the parent developed, because we need to also consider whether it may impact our treatment. And it's important to use your knowledge of neural development to conceptualize some of your clients' difficulties um, and maybe some of their families' difficulties. So, um, when we think about intervention, how do we intervene? What do we do to intervene? We know that positive relationships between children and their caregivers moderate these brain behavior associations um, in children and adolescents. So I know that developmental text, the common knowledge says, like, oh, adolescents, parents are less important. But there is neuroimaging data that's coming out now that suggests, yes, parents may be socially less important, but to the child's brain development, they're actually not less important. And so continuing to help our patients have positive relationships with their caregivers, no matter whether they are early childhood, middle childhood, or adolescence, is really important because it can impact some of these adaptations that the brain is making based on the adversity the child has experienced. Um, so when we think about the finding that adolescents who grew up in poverty had reduced connectivity in the central executive network and reduced connectivity in the emotion regulation network, what I didn't say then, but am saying now, is that actually that's only true for children whose did not have a good relationship with their primary caregiver. So what they found is that caregiving relationship moderated that association. So we can use this to our advantage. We can increase caregiver sensitivity. We can increase the caregiver's predictability, and we can increase caregiver regulation, right? Because a lot of our kids, they're having difficulties regulating emotionally, but if their caregiver can't regulate themselves, they're going to have a very difficult time helping their child regulate. And we know that the developmental process of self regulation starts with co regulation with the caregiver, right? So we need a regulated caregiver to teach regulation strategies to a child. Um, So, given the findings about the default mode network and rumination, and how adversity increases the activation of the default mode network, we know that third wave behavioral therapies like ACT or engaging in daily mindfulness has shown decreases in default mode network connectivity longitudinally. Um, so if you have a child that's ruminating a lot or seems to have a lot of negative self thoughts, um, then maybe using your knowledge of, okay, well, if they have a lot of negative self thoughts, they're probably doing lots of rumination. We can interrupt that DMN connectivity with meditation. As I alluded to earlier, regulation. So, increased practice of regulation strategies can help the inefficiency that we see in some of these networks between the really strong connectivity between the medial prefrontal cortex and the amygdala. And so, continuous practice of emotion regulation to make the connectivity between those two regions more efficient. Um, and of course, as I alluded to, you probably need parental participation because a lot of our kids can't self regulate, right? Um, what we know, because we have the increase in the salience network for maltreated kids, um, to reduce that connectivity of the salience network, we want to use exposure-based treatments. So if we have a child who is um, really attending, seeing everything as a threat, we want to use exposure-based treatments to reduce that connectivity because there's new learning that's taking place that when A happens, B doesn't necessarily happen, right? Somebody gives me a mean look, that doesn't mean I'm going to be hit every time, right? And there's new learning that occurs to reduce that salience network. Um, Using behavioral strategies like specific praise, caregiver attention, token economies, that brings those sort of really speak to that amygdala medial prefrontal cortex hyperconnectivity. And so when the environment is predictable, when I can plan for rewards, that helps to reduce my bias towards it helps to reduce my bias in this with the salience reward network, um, and it helps make regulation more predictable and efficient. Um, and when we've got really difficult behaviors, I really encourage doing a functional behavior analysis because it's hard to always know what preceded a certain dysregulated behavior or a certain thought. And so, really being intentional about our ABCs, antecedents, behaviors, and consequences. Um, so that we can target specific behaviors, being very mindful of what is the likelihood that this is related to a brain connectivity process that we need to interrupt through lots and lots of practice. We're also thinking about how does neuroscience um, impact the future, what we're thinking about, what we're working towards. So the a lot of our psychotherapeutic treatments, psychiatric medications, really focus on neurotransmitters, and it makes a lot of sense, right? So we use um, we use medications that either increase or decrease the uptake a reuptake of a certain neurotransmitter. But we also know that if social connection moderates or impacts the way these brain differences develop, then can we increase um, the social connection piece through oxytocin to reduce some of these effects without altering the neurotransmitter quantities in the brain. So people are looking into that. Um, we're also looking at biomarkers to determine which treatment might work best for whom, right? So there were lots of different associations that I talked to you guys about, and a lot of this is still sort of, we're going to use our best knowledge to make our best treatment approach. We're going to conceptualize very carefully. Um, but for most clinics, they're not going to have the imaging technology to be able to say, okay, this is the network that we need to target, right? And so can we find biomarkers of those connectivity adaptations? So if we see high skin conductance paired with a high CBCL for externalizing, right? This is actually just hypothetical, I don't know. But if we have these sets of data that all suggest, okay, this is 95% confidence that the amygdala medial prefrontal cortex connectivity is hyperconnected. Okay, well, maybe we should try this particular treatment, right? So not requiring the use of imaging modalities, but having some kind of biomarker to determine what is the likely neurocircuit or neuroadaptation that's driving some of this behavior. And then something I'm specifically working on is real-time neurofeedback using the functional near-infrared spectroscopy system to look at brain responses to our typical interventions like praise or timeout. And how is the child's brain perceiving that? What is the child's brain doing in the exact moment that we intervene, so that we can, one, make sure that we're not harming the circuit in some way, and two, to say, okay, the brain response to this particular intervention wasn't great. Let's try a new one. And so that's what I am currently working on. So we have about 8 minutes left, and I would love to answer any questions people have. Um, I have a K-12 that's funded through the UAMS TRI. And so this is just the notice that I'm funded through there, and I have to recognize my funding source. So thank you so much for everybody's time and attention.
Thank you. Excuse me. Thank you, Dr. Calvert. That was amazing. We have Valerie McDermott has a question. Valerie, if you'd like, you could speak or put it in the chat. If you are speaking, you might be muted, but we have someone asking, do these neuroimaging results hold up cross-culturally?
So there's been a recent push within the last 10 years to increase cross-cultural representation within the neuroimaging research. And so the I would say that yes, and um, all the work has not been re um, redone with more diverse populations. So, in the poverty specific findings, those have been found cross culturally. In some of the maltreatment and parental conflict, the I'm trying to think of the exact samples. I guess I can't speak to those two findings as specifically as the poverty. But I do know that they are working very hard to increase representation in neuroimaging studies. And there's cross, um, a multi-site study of 2,000, or I'm sorry, 12,000 families, and they tried very, very hard on all types of diversity. And so those studies are being currently done. We just don't have all the results yet.
And we have another question here. Do you check all this on the kids at the PRI inpatient program?
So I think that is a really good idea. But we have not been, I have not recruited any patients from the PRI inpatient program at this time.
Right. And let me just tell everybody how they can get a hold of their CEUs. As people are starting to sign off. And if there's any questions, we're happy to stay on and answer them. But for those interested in receiving a CEU, after the webinar, I'll send a follow-up email with a link to today's participation survey. If you fill out that survey and when prompted, put in the code for today's webinar. And so the code for today's webinar is 8190. I'm going to repeat that and then put it in the chat, 8190. If you'll just be mindful that it takes a minute for those to get sent out, so just submit your survey and please be patient. And note that the CEUs are only given to those watching this webinar live and cannot be provided to those watching it on YouTube. Let's see. Fantastic presentation today, Dr. Calvert. I appreciate it so much. Just going to see if we have any questions. Oh, 8190 is that code. All right, with that, I think. Oh, here's one question. Sorry. How would oxytocin be used in treatment? Intranasally?
So that is not my specific line, but that is my understanding, is that it's used intranasally, yes.
I have Jennifer saying I'm a big fan of Dan Seigel's window of stress tolerance and the hand model of the brain and the related approach, conscious discipline by Dr. Becky Bailey. Do you recommend these resources as well for your family therapy, or do you have any other go-tos?
Yeah, so I do recommend those. I also typically use the child parent psychotherapy website to find resources. They tend to have lots of really good books and suggestions on sort of the emotion processing side. And so, yeah.
And one more question. Do the treatment options consider working with the possible dysregulated parent to learn how to heal their brain so they can better take care of the child?
So from my perspective, I think that the science indicates we should be doing that, right? I know that child parent psychotherapy does have a specific um, recommendation to help the caregiver with regulation in order to help co-regulate their child. Um, and that if their own mental health difficulties are impacting treatment enough, that we refer out to another provider. And also in TFCBT, trauma focused cognitive behavioral therapy, um, there we teach the child regulation, but also the child should be teaching the parent. And if regulation difficulties are noted, it is allowed in the TFCBT protocol to do some parent only work around parenting, which would include regulation if they're having difficulties.
Absolutely. All right, I think that's all of our questions for today. Thank you so much, Dr. Calvert, and thank you everyone for joining us for this webinar.
Thank you so much.
Have a good day.